And there are a lot of organ-preserving choices, that is GnRH. Uterine, suddenly these have increased. We've had one woman who's conceived the second time with the uterine artery embolization. We have another woman who's had an MRI-guided focused ultrasound and cryotherapy, and she's pregnant. So more and more of these new approaches have come up. More and more women are getting pregnant with these conservative options. So we need to be aware of what are the problems in them in the subsequent pregnancy. Miscarriage, I won't. What we would do is IVF and myomas also, they had spoken. Just a word, because these were topics which we did in the conservative surgeries, because these are coming, uterine artery embolizations. This is done very commonly. This woman is now in her second pregnancy, and she told us this was done because this was before her marriage. It was a large 12-centimeter fibroid. She said she did not want anybody to touch her uterus. She went onto the net, got this procedure, and she had one baby cesarean section. Now she's come to us in the second pregnancy. She's almost 37 years. So this is a reality today. So what are the problems when they have a uterine artery embolization and they come to you with a subsequent pregnancy? What do we do? Do we do anything different for these women? They have a much better improvement in menorrhagia because there is an avascular shrinkage of size of the fibroid. Certainly, they have no impact on fertility, no impact on fetal growth, and no impact on integrity. That is the big advantage. If a woman has had a uterine artery embolization, it is just a local shrinkage of the blood supply. The rest of the uterus is actually quite normal, so the scar integrity is not of much concern. So is there any evidence? Yes, there are 56 pregnancies which have been followed up after uterine artery embolization. The significant increase in delivery by section, significant increase in preterm, PPH, miscarriage, lower pregnancy rates, and they may again end up with lap myomectomy. So that's the risk. Again, the uterine, because you're actually blocking the uterine arteries, there could be, and there's irradiation, you could have amenorrhea and ovarian compromise. So that's the important effect, that they may not conceive at all because you're the uterine artery embolization. You may end up in undented hysterectomy. So if you tell a woman that yes, now you've got a large fibroid, you have this choice, you have to be aware of what the risks she has, what are the benefits she has. And post-embolization sepsis from necrosis of a large mass of tissue especially. So we have to be careful when we give her this choice. What about laparotomy? Laparotomy is when the fibroids are very large. We have said that myomectomy, laparoscopy, it's when they are between 4 to 8 centimeters, they're not more than 4. So very clear guidelines have come, I think, and we need to stick to these. And laparotomy is intended when there are multiple myomas and when there are deep intramural leiomyomas. The myomectomy, like we've said, could be hysteroscopically, could be laparoscopically, could be by laparotomy. Laparoscopy, we have covered this. Yes, but what happens to the conception rate? They have a very good conception rate of 55% and a live birth rate of 80%, which is similar to those with other procedures. What are the risks when you do a myomectomy? We have to remember that they can have a scar dehiscence. That's the only risk that they have. And the risk is almost equivalent whether you do it laparoscopically or with a laparotomy. The risk that she has is about 1%. That is in the antepartum period. And the risk is always about 2.5% in labor if the cavity has been encroached. Recurrence rate, we remember that there is a 15% recurrence rate, and 10% of women who have undergone a myomectomy will eventually require hysterectomy within 5 to 10 years. What is myolysis? Again, these are conservative things which have come where you give energy or you give cryotherapy to the fibroids to let them shrink in size, and this is done when the fibroids are less than 5 centimeters and less than 4 myomas, not more than that. This is another study which is very interesting where they have done pregnancy post-embolization versus myomectomy, and you find that the pregnancy rates are much higher with myomectomy rather than uterine artery embolization. And this we said it's because of the ovarian reserve, ovarian damage and amenorrhea which you could cause. The deliveries are better. Everything's actually better. So do we really tell our women to undergo uterine artery embolization? It's a food for thought. Another procedure, MRI guided focused ultrasound and cryotherapy. Again, this is a local destructive procedure. Mean time to conception is 8 months. Term deliveries were noticed in 93%. Placenta previa was seen in 9%. So when a woman comes to you with this, it's very, very, very important to look at where the placenta is and is there any placental adherence. To give you some important salient finds, whenever a pregnant woman comes to you with fibroids or you've diagnosed fibroids, a careful scan and documentation of the number, the size, location, consistency, vascularity, and relation of the placenta to the uterus. Outcome in fibroids is related to the type of fibroid, whether it's submucous, whether it's intramural, is it subserous, how many numbers are there, and where are they located? Is it in the fundus? Is it in the cervix? Is it in the mid portion? The LSCS rate is certainly high due to malpresentations. Avoid myomectomy during sections unless the 3 indications that we mentioned. Be ready and anticipate and prepare for postpartum hemorrhage. Do look for adherent placenta in post-myomectomy patients. Thank you.